Now it's going to be our chief instructor, Dr. SUBINA Narang. She's a professor in Medical College, Chandigarh, and she's going to give us the classification as well as some case-based, showing some cases. Dr. SUBINA, please.
Thank you, sir. Now I'll be talking about the latest classification, which is given in 2021, and a few cases, ROP cases, along with the classification. So why do we want to classify ROP? That is to give one common disease language so that we can classify, document, and identify ROP needing treatment. The first classification was given in 1984, which classified ROP on the basis of location of ROP and extent of ROP. In 1987, it was retinal detachment was included in the same classification. In 2005, there was revision, and we added aggressive retinopathy of prematurity to it because we were having more and more of aggressive cases. In 2021, we have revised this classification because we have newer imaging techniques and better treatment facilities and better neonatal survival. So we have a few modifications which have been made. Now, ICROP 2021, the location is practically the same, zone 1 ROP, we all know. With disc at the center, you draw a circle, the radius of which is twice the distance between the disc and the macula. And in case in your busy clinical setting, you cannot identify what is zone 1, then you take 28 diopter lens. If the edge of the disc, nasal edge of the disc, is coming at the edge of the field of your 28 diopter lens, the area, whatever you are visualizing, is zone 1 ROP. Area beyond it, 2 disc diameter, is called posterior zone 2 ROP, especially to take care of the babies, like sir was showing. The heavier babies and older babies in India are having aggressive ROP in zone 2 posterior ROP. And then from the nasal part of the zone 1 till the nasal ora serrata is zone 2 ROP, and the temporal crescent which is left is zone 3 ROP. Now they've also added a term notch. Notch is in case we see that there's incursion of the ROP lesions in the posterior zone for 1 to 2 clock hours. In these kind of cases, we document is like zone 1 secondary to the notch. So this notch, a very careful examination will show this notch in some cases. This is how you have to document that. And now coming to the severity of ROP, if you see a line between the vascularized retina and avascularized retina, this is stage 1 ROP. You could see some arteriovenous malformations just posterior to this line. If this line gets a volume, it is stage 2 ROP. If you do fluorescein angiography here, you will pick up some arteriovenous shunt vessels. And if this gets there's raised extraretinal proliferation, fibrovascular proliferation, you will see that the posterior part of this is in continuation with the fibrovascular tissue there, and these are perpendicular to the ridge. So this is what it is. If your retina is detached, stage 4A if the macula is paired, and stage 4B if your macula is involved. And if you have total retinal detachment, it is stage 5. If the bedside examination, you are able to see the optic disc, then it is 5A. If optic disc is not visible, it is 5B. And in case anterior segment is involved, it is 5C ROP. You must carefully examine the junction of vascular and avascular retina. If at junction you are able to pick flat neovascularization, it is aggressive ROP. If these babies are not treated in time, then this would straight away lead to stage 5 ROP, and it doesn't pass through various stages of ROP. We are seeing this kind of aggressive ROP even in anterior zone. Now this is lot of dilatation and tortuosity of vessel, and this is zone 2 ROP. And once you carefully examine, there's neovascularization, flat neovascularization here, which is aggressive retinopathy of prematurity. This has also given a new dimension to plus disease. Now the plus disease is called a continuous spectrum of retinal vascular changes. Increased vascular dilatation and tortuosity could be in the form of pre-plus disease. It's a continuous dilatation and tortuosity, or plus disease. You have to see the posterior zone 1 in totality and see how much dilatation and tortuosity is there. Now this is the patient who comes to us. There's a lot of dilatation and tortuosity of vessels and one hemorrhage which is there We do fluorescein angiography to see whether this patient has flat neovascularization. We are missing, but there's no flat neovascularization. The patient progresses, and you start seeing neovascularization. The careful examination show, however, just to document, we did fluorescein angiography, which is showing leakage here. So this is aggressive ROP, which you have to treat. Now, after treatment, you start seeing regression of ROP. The classification also comments about the regression. The regression could be seen, there's decrease in dilatation and tortuosity, which we are seeing after laser treatment in this patient. It could be seen after anti-VEGF also. In anti-VEGF, the regression is 1 to 3 days, and with laser treatment, it is 7 to 14 days. The vascularization, there could be persistent avascular retina after regression, especially with anti-VEGF. If you have to document that, you have to document the zone in which you are seeing posterior persistent avascular area. Here it is persistent avascular zone 3. The vascular changes of ROP could show reactivation on the time you are following up these babies. Especially after anti-VEGF agents, you start seeing the vascular dilatation and tortuosity again. You will see frail neovascular fronts. There could be hemorrhages around those neovascular fronts. So careful examination has to be done for reactivation of ROP. And if multiple ridges are present, especially after anti-VEGF treatment, you will add a modifier. Reactivated is applied to the most anterior edge what you would be seeing. You could see this kind of reactivation after laser also. This patient was taken up for laser treatment as well as anti-VEGF treatment. At 3 weeks follow-up, you see this dilatation and tortuosity has decreased. So it looks good. But once the patient comes back for follow-up, there's reactivation in the form of ridge coming up again. So you have to really maintain the follow-up in these babies till the time you see total regression. And then again, for sequelae of ROP. This is a lifelong follow-up for any ROP baby. In case you have reactivation, just try looking for these avascular areas or skip lesions which could be left behind. So you have to address these areas for complete regression of ROP. Long-term sequelae of ROP, apart from the foveal, shallow foveal dip or persistence of inner layers of fovea, there are other things which happen due to residual peripheral traction areas. They could be macular drag, disc drag, there could be straightening of vessels, and you could pick up certain things on macula also. This was stage 4B ROP. We've done fairly good treatment, happy with our treatment. Once the patient is maintaining follow-up, 4 years follow-up, the patient starts showing this lesion in the macula. However, the vision continues to be 20/60, which is a good vision. But you do OCT for this baby, there's this, looks like probably a spontaneous closure of macular hole. So now we've seen that if you do vitrectomy, you must maintain the follow-up. You do have some macular problems which are coming up late during the follow-up. Summarizing, AIOC3 should be followed to describe and document ROP. It is an integral part of any ROP evaluation. Classification gives uniformity in describing location and severity of the disease. The documentation as per AIOC3 is must in the present scenario, plus the medical legal issues will also be discussed subsequently in this course. You will realize that it's very important to document, even whether the drops are dilated or not, the pupils are dilated or not dilated, how you have examined, and you have to give the next date. This is the performer which we follow in our practice. Thank you.
Thank you, Dr. Subina, for giving such a clear understanding, especially about the new classification which we all have to follow, and how we should be documenting each and everything. Even if we don't have cameras, we can always have good diagrams, and you label it very well.